Top Med Talk.
Hello and welcome back to Top Med Talk here in Philadelphia for the Anesthesiology 2024 meeting. It is the annual meeting of the American Society of Anesthesiologists. I'm Desiree Chappell, your host. I'm joined by my co-host, Professor Mike Grocott. Hello, Mike.
Hello again, Desiree.
Yes, we are at it. You're going to see us a lot here on Top Med Talk over the weekend. But we have a very special guest with us, the founding editor of Top Med Talk, Monty Mythen.
Great to be back, Desiree. Thank you for letting me jump in.
Yeah, it's fun, Monty. I'm glad you could join us for a little while. I know we've been saying this a lot, but each one of these pods are unique. So you left Top Med Talk as editor-in-chief last year.
So I joined the company Edwards Life Sciences Critical Care. I'd retired from the NHS and the university. I'm still there as an emeritus prof. So I joined an industry partner and one of the sponsors of Top Med Talk, so I thought it appropriate to step down, and you all said that's a good idea.
Yeah.
Very quickly.
Yeah.
We did it.
but both parties have said that I can guest,
Yeah.
providing, we respect the fact that there are potential conflicts of interest. They're all declared. Edwards is a founding sponsor as well of Top Med Talk to allow it to be free and open access. Edwards Critical Care has now been acquired by BD, Becton Dickinson, so I'm now part of BDAPN, Senior Vice President for Scientific Liaison and Professional Education.
Well,
what we're doing right now.
Congratulations. That is amazing. Monty, for our listeners who may not be familiar with Top Med Talk, because we have a lot of new listeners here at the meeting, tell us a little bit more about when you founded Top Med Talk, what your goal was for this platform.
Remember, this is BC, before COVID.
Yeah.
So we were part of being involved in lots of great conferences, and many, myself and Mike and others, ran ourselves under the guise of evidence-based perioperative medicine, going for over 25 years now. And we're feeling embarrassed about having these great conversations in an echo chamber. We knew that there was a much bigger audience out there, and this is before a lot of people were podcasting, etc. We felt as though we should do our best to broadcast the events, so we started by live, let's call it radio broadcasting.
Mm-hmm.
And then I couldn't go to one meeting in Washington, so we decided to start doing a podcast as well. And that was the birth of Top Med Talk. Mike, you were on the first one, I think.
Was I?
Yeah.
Oh.
I hadn't appreciated that.
Well, maybe.
When they're the first ASA meeting.
Yeah, okay.
Yeah.
And from then, we formed it as a podcast, and it wasn't long until we got over our first 1 million downloads, which was, our first goal was to get 10,000 in a lifetime.
Yeah.
Now we're into the millions.
I know. Pretty amazing.
Part of it is the quality of our guests.
It is the quality of our guests. Thank you for that wonderful segue, Mike. So we have wonderful guests over this whole weekend, but really outstanding gentleman who could join us today, Dr. Assad Usman. Assad, thank you so much for joining us. For our listeners, why don't you tell us a little bit more about yourself?
No, thank you so much for having me. This is a real treat to be with these guys here. I've listened to the talks before.
Oh, thank you.
It's welcome respite when I'm driving home from work, and I listen to a podcast and I learn something every day. So I am an anesthesiologist and intensivist. I practice cardiac anesthesia and ICU at the University of Pennsylvania, and I'm in a unique team, which is an ECMO and mechanical circulatory support team at the University of Pennsylvania. We have a number of anesthesiologists that are part of our team. We have a mobile component to our program, which I was talking to you guys about earlier. We fly out maybe 60, 70 times a year for mobile ECMO for patients in and around the region. We've had patients all the way down from Florida come during COVID, and so I'm part of that team and manage patients who require cardiopulmonary support, typically with mechanical circulatory tools, and that's what I'm here to talk about today.
Yeah.
And forgive me for adding just a little bit of color to this. That's not the only flying you do, is that right?
Yeah, so, my father-in-law is a pilot, actually, and I've been out in the plane with him as well. So
and the helicopters?
Helicopters as well, yeah.
Yeah, so the headset is like just normal.
Exactly, except it's a little louder in the helicopter.
Oh, true.
Desiree, can we decode a little bit, because we throw the term ECMO around, because we're used to referring people for ECMO or perhaps putting people on ECMO. Can we just expand on that a little bit?
Totally.
For the layperson?
I think it's important to talk about the hierarchy of mechanical circulatory support. And originally, mechanical circulatory support or extracorporeal support, which is outside the body, support started in the 1960s. It's with dialysis, right? So the original description is the ability to take blood out of somebody, put it through some sort of filter with a pump, and then put it back into them, replacing some part of their body function that may not be working. So at that time, it was kidney function. So that's where the original term extracorporeal support came from. Then fast forward, we developed tools that are for mechanical support, which would refer to the heart, or oxygenation, which would refer to the lungs. So when you have something like extracorporeal membrane oxygenation, that is a tool that provides oxygenation to the body. It's independent of the actual pump. The pumping function would be mechanical, the support part of it. So you could have something like a balloon pump, you could have something like an Impella, or you could have something like a durable VAD, which would be in that category. So when we talk about ECMO, it's under the rubric of mechanical circulatory support.
So everybody who knows somebody who has had open heart surgery, for example, going back into the last century, that person would have gone on something that looks a bit like ECMO as we talk about it today. So the pumping of the blood and the oxygenation takes place in a machine outside the body.
Yeah, that's actually correct. And actually, we are in the birthplace of cardiopulmonary bypass.
Oh.
Right up the street here, Dr. Gibbons did his first cardiopulmonary bypass operation, and it's done at Pennsylvania Hospital. And at the time, it was 1962, and Walter Lillehay, who is a famous surgeon, developed the Lillehay oxygenator. And they had a young girl who was 19 years old who had an ASD. And they wanted to operate on her right here. It was at that time Thomas Jefferson, Pennsylvania Hospital. And they took her to the operating room, and this machine was gigantic. I mean, you had to put like 10 liters of extracorporeal blood into the circuit to actually do the bypass. And so the bypass, I want to say in the original description, lasted anywhere from 15 to 19 minutes. And the case was an utter catastrophe. The patient was bleeding out left and right, but eventually she ended up surviving. Dr. Gibbon, who did the original surgery, he was a proud man, and he promptly retired after the case because it was the first. Before this, several patients had died trying to go on bypass, so he was the first successful one. And then he went on a very much of a 1960s top med talk circuit around the country, giving his talks about how he was so famous and he did this case. And so, yeah, that's where cardiopulmonary bypass started, right here in Philadelphia. And it's nice that we can talk about the advancement of where we're at now in terms of mechanical support.
And then people started to bring it into the intensive care unit. So I remember as a very young doctor in London, then bringing the heart-lung machine down to the bedside of a young lady who she'd had her baby. She developed a bad lung injury. She was dying. So they brought the heart-lung machine down to the intensive care unit as sort of very early days of what we now call ECMO.
Mm-hmm. Actually, that's interesting you mentioned that. So I went to the University of Michigan, and the reason I got interested in mechanical support is because of Dr. Bartlett. Dr. Bartlett is considered the founder of this subfield. So I worked in his lab, and the original story is that he was at the Peter Brent Hospital at Harvard, and when he was a surgical resident, he was tasked with figuring out how you can bring this pump out of the operating room to use in the intensive care unit. And then he went to San Diego, and at San Diego, he was working on sheet, putting different types of pumps, Jarvix and ECMO circuits and centrifugal and pumps into patients. And so there was a mom who crossed the border and had a newborn who had a respiratory distress of the newborn. It's a catch-all phrase in the 1970s of, like, baby not doing well. So they asked Dr. Bartlett, can you try your machine on this baby? And the mother actually ended up abandoning the baby in the hospital. She was, came across the border undocumented. And so Dr. Bartlett that morning polished off the machine. There was no IRB required, cleaned it off of blood, and put this kid on ECMO, saved the kid's life. And that's sort of where the growth of extracorporeal circulation really grew. Yeah.
So I've got one last thing, because in those early days, we didn't have pipes that were designed for the job. So I remember that specific case, we used pediatric endotracheal tubes to enable the cannulation. And then the big challenge was the machine breaking up the blood cells and the anticoagulation. Now I'm going to be quiet now for a while and jump right forward to the new kids on the block.
Yeah.
Mike, did you have something you wanted to mention?
Yeah, well, I absolutely again the same way, because it's probably only about 18 months I first heard about this technology, and I couldn't quite believe what I was being told when I sort of first heard the lecture. So talk us through, where are we now?
Oh, well, I mean, this field is phenomenal. Obviously, the reason I love it, my dad's an engineer. He worked at Ford. He works at Stryker now. So, growing up, I was really fascinated with the idea that you could replace the cardiac function with pumps, right? And so Abiomed has been around for a very long time, and they were also producing pumps, both durable pumps and temporary pumps. But most recently, the new kid on the block, as you mentioned, is like an Impella. Impella is like an Archimedes screw. So the extracorporeal ECMO circuit is a pump that is, magnetically levitated disc that is centrifugally flowing. This pump is a Archimedes screw that transverses the aortic valve, and it is placed through an arterial vessel, either in the groin or in the upper extremity, and it crosses the aortic valve and then sucks the blood out of the left ventricle and propels it forward into the aortic root.
And the procedure is, if I understand it correctly, is like coronary angiography and stent placement. It's in a cath lab.
Oh, absolutely, absolutely. One of the interesting things about the Impella, they have different, ranges of tools that you can use. The two workhorses right now, one is called the Impella CP, and the other one is an Impella 5.5. And the Impella CP is typically placed through the groin, and it's a percutaneous access. And the Impella 5.5, in its current iteration, is a surgical placement through a graft. However, as this technology grows, and anyone who's worked in this field knows that the limitation is only technological. In the future, they have in the pipeline ways to deploy this tool that is giving up 5.5 stands for 5.5 liters of flow, which is typically how much a normal BSA patient needs for adequate cardiac function, can in the future potentially will be implanted percutaneously at the bedside. And so I think that those are the sort of things that are up in the pipeline, and we've been using an Impella for the last part of the decade, and it's been an excellent tool for patients who are in cardiogenic shock.
Can I ask a quick question? This is my naive, I'm sure. And I worked when I was in critical care, we had just a normal balloon pump.
Yeah.
How is this different from, and what has the evolution been from a traditional balloon pump, like an IAB, intra-arterial balloon pump?
So the intra-aortic balloon pump has been around for a very long period of time, and it was really the workhorse, go-to tool for cardiogenic shock. Its advantages were that you could implant it very easily. It wasn't just sort of at big hospitals. Small cath labs could implant it. You could travel with it. And so the balloon pump, it augments flow during diastole. So the balloon inflates during diastole, allowing for more coronary flow, and then it deflates. And during the deflation, it causes a decrease in your afterload and subsequently allows blood to move forward into the aortic root and to the rest of the body. The Impella is different. It actually crosses the aortic valve, and it has like a screw-type mechanism, and it sucks the blood out of the left ventricle and then injects it into the aortic root. It doesn't matter if it's systole or diastole. It is continuously flowing. And it not only it decreases your left ventricular end diastolic pressure, which is how big the ventricle is distending, but also allows for forward flow during systole and diastole. So enhances coronary flow, as well as sort of flow and perfusion throughout the rest of the body.
Now, we've been lucky enough with some of our EPPOM meetings and some of the podcasts earlier in the year. That if we look back at the history of ECMO, one of the clouds over it was always, where's the evidence? Now, with Impella, as far as I understand, it made this giant step forward that there's a New England Journal of Medicine publication that shows a very meaningful difference in outcome.
Absolutely, yeah. I think that, one of the advantages that Impella has is it's more physiologic. It makes more anatomic sense and physiologic sense. The disadvantage to ECMO is that typically when we're talking about veno-arterial ECMO, it's retrograde flow, right? You place the standard setup for peripheral percutaneous ECMO is through the femoral artery with blood going retrograde, which then causes the ventricle to distend. In the initial phases, when somebody is in shock and you're in real trouble, you can deploy it very quickly. But after a couple of hours, you have the complications that result from that. Whereas Impella is the natural sort of cadence or the natural path of where the blood is supposed to go. And so that is the real advantage. And now, as you mentioned, the New England Journal of Medicine article, but within subpopulations, if you look at bridge to VAD, patients who require heart transplantation, bridging to heart transplantation, those with non-ischemic cardiomyopathy, those with ischemic cardiomyopathy, and also just patients who could potentially recover, those patients really have shown us distinct advantage with Impella use as opposed to ECMO.
So that particular paper, I think, was cardiogenic shock.
Yes.
After there'd been an intervention in the cath lab,
Correct.
etc. And then one of the discussions we've been hearing, which reminded me of the story way back in the day, that although lives were saved and outcomes were better, that there was some, potential collateral harm that goes with the technique, which presents an opportunity. So overall, it was a big win as far as I could see. But there's also opportunities there to improve things.
I think with all these tools, there's always going to be some limitations because you're going to have to access the vessel. In any of the tools, balloon pumps, ECMO, Impella, you're going to have the collateral injury with, vascular access. The blood is being exposed to a foreign surface, so you're going to shear some of the blood. And that is for this whole community to develop technology that continues to enhance the ability to not destroy the blood or create smaller tools. One of the nice things with the Impella is that they are ranges that you can choose of the device. I would say that the sort of like Achilles heel or like sort of the shining light of this situation with the Impella is now it's become like not only just a short-term tool, it's a subacute tool, right? Patients you can keep them on for 3-4 months, and in a meeting like this with the anesthesiologist, they're going to continue to encounter more and more of these devices. Many anesthesiologists take care of VAD patients. We know that because VAD are durable devices. Many anesthesiologists don't take care of ECMO because you can only be on it for a short period of time. As the technology of this newer device develops, patients can be on this for 6 months, 9 months. So what ends up happening is most general anesthesiologists will encounter this tool in their day-to-day practice because they're going to have patients coming from the floor who need colonoscopies, who need radiology procedures, IR procedures. Recently, I had a patient who was getting bridged to transplant, and she had an Impella, and she needed her uterine cyst evaluated. The gynecologist felt comfortable, the anesthesiologist felt comfortable taking her to the suite, doing an ultrasound on her, doing a transvaginal ultrasound, and taking a look at the cyst. So, it's much harder to do something like that when you're on ECMO, and it's very common to do something like that when you're on a durable VAD device.
Cool. And as we've touched on, there are some adverse consequences. How much of those are going to be solved by refining the engineering, so making the device itself better, and how much do you see as being sort of other countermeasures that will enable us to mitigate some of those challenges?
I think it's 50-50. I'll give you an example. So recently during COVID, when we were doing VV ECMO, we recognized that patients who were on heparin had a higher rate of intracranial hemorrhage. And that may have been a real logic problem with COVID, but you're also introducing an extracorporeal circuit. So we switched to using bivalirudin in these patients, and we saw a decrease in stroke rates. If you look at the same counterpart conversation in Impella, you see that you have to give a purge solution that allows that rotor to stay patent. So initially we were using anticoagulation, but you can use sodium bicarb now. So that actually gets rid of the entire anticoagulation equation. So that must be a combination of engineering as well as understanding the patient physiology, because we can't just treat the machine. You have to treat the patient. So some patients are more coagulopathic than other patients. So that's just one small example. The other example would be miniaturization. So the ability to deploy the device intra-arterially can be shrunk down and then expanded when you go intra-arterially. So that's sort of the technology that they is coming up in the pipeline.
Yeah. So, I'm sitting here listening as an anesthesia professional. How is this going to impact my care? What are some of the considerations that I need from a frontline provider when an Impella shows up in my OR or when we're having to do an endoscopy or something like that?
Well, in my perspective, I think there's 3 or 4 key areas to talk about. First is if you are a general anesthesiologist, right? So these devices are going to be in, let's say, 6 months to a year. These patients are going to come to your operating room for routine procedures, colonoscopies, right? And unlike the VAD, when a VAD coordinator comes to help you out with the Impella, the patient shows up from the floor, and you have to sort of work through these issues. How are you going to monitor the blood pressure? How are you going to anesthetize this patient? Are you going to induce general anesthesia? You have a powerful tool. You have to be able to understand how to sort of change the dial on the device to go from what the terminology is P levels, P3, let's say they're set at P3, gives you 1.5, 2 liters of flow. You can crank it up to P7. You get like 5 liters of flow, and then you induce the patient. You have very, very little risk of having a cardiac arrest at that time. So that's for the general anesthesiologist to understand the tool and the device. Then there's a subgroup of us that are cardiac anesthesiologists that encounter two variable situations. One is when you're working with a heart failure surgeon, and in those cases, you have to consider how you're going to anesthetize these patients. Could you potentially do this under regional anesthesia? Mm-hmm. So in our group at Penn, we wrote 2 papers. One is in JACC and one is in JCVA, talking about implanting an Impella 5.5 under regional anesthesia. No general anesthesia needed at all. Wow. So you can just use pectoral blocks and interscaling blocks with some TIVA type setup like we do in TAVR with MAC sedation and implant the device and mitigate the downside risk of arresting a very, very sick patient who needs to get the Impella out of the gate. Then the other group for the cardiac anesthesiologist is if you're working with a non-heart failure surgeon. Mm-hmm. Let's say you're doing an aortic case, type A dissection. You have cardiogenic shock post-operatively. The reflex of that surgeon is to use a balloon pump or maybe ECMO. But now you have a new tool that has more advantages and less disadvantages. So you may want to advise your surgeon to use an Impella device in this situation. So that would be the third scenario. And then the last scenario, which is a large percentage of us, are intensivists, right? So you have patients that you're covering overnight. Your patient comes in with cardiogenic shock. And again, many hospitals have the ability to deploy a balloon pump. But the question becomes, why can't you deploy an Impella at the same time? Or use that instead. And I think the way the technology is going and the way that our skill set is going, given my expertise, like you can see that there's many anesthesiologists, intensivists in Europe that deploy ECMO. Why can't we deploy an Impella CP if that's the better tool with the skill set that we have? We have all very good vascular access skills. We are taking care of patients in the ICU. And so, I think that's what the future is going to hold for those patients, those of us who practice in the ICU. Middle of the night, patient comes in with cardiogenic shock. You talk to your colleagues, heart failure colleagues. You talk to your surgeons and think about what tool to use. And that may be one of the tools you have in the armamentarium.
Yeah.
It feels to me as an old guy who's just stepped away from the bedside. You mentioned right at the beginning that, hemodialysis on the intensive care unit was the first extracorporeal support. Now, I remember when that had a 100% mortality rate and was only performed at very specialist centres. And now you wouldn't bat an eyelid by putting somebody on extracorporeal support for the kidney. Everyone does it, and everyone does it remarkably safely. It's not always perfect, but it's solved a lot of problems. It feels like we're making that sort of transition for the heart. What it feels like to all.
Yeah, I agree. I mean, I think the limitation is the size of the tool.
Yeah.
As we continue to miniaturize it, you can foreseeably see it being deployed not only in tertiary and quaternary centers, but there could be a world where you're a general anesthesiologist, you have a patient with an index of 1.2 who's coming for a HIP, EF of 10%. Why can't you put an Impella in temporarily to induce that patient? And that will be the wave of the future for some of these patients.
So we've got a very tightly defined indication currently by the trial, but the prospects are extraordinary.
Yeah, I think a lot of us who practice anesthesiology, when it comes to actually managing the patient, you have the trials, but you have to take care of the patient that's in front of you, right? Yeah. So if you have somebody who's crashing and burning in front of you, you're going to use a tool that you have available to you.
This is incredible, really exciting, new for many of us to hear about these devices and the prospects, as you said, the potential to impact the care that we're delivering, because we know that we're taking care of much sicker patients, higher comorbidities, and some really ill patients. So thank you so much, Asad, for talking and sitting down with us. I know you are working, you're working locally, so very busy on call in a very busy meeting. So thanks for taking the time out. Hopefully we can catch up again soon.
Definitely. Thank you so much for having me. This was excellent. Thank you, bro.
Fantastic. And thank you for listening to Top Med Talk. You can always find us on social or on X, LinkedIn, Facebook, YouTube. If you find us there, give us a little thumbs up. Every little bit helps. And there's going to be more this coming weekend here at Anesthesiology 2024. Cheers, everybody.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.